So the first question was, what if the patient is bedbound or other reasons make it so that you are unable to weigh the patient? We had a lot of questions about weight. If a patient cannot be weighed, for example, because of extreme pain, immobility, or risk of pathologic fractures, the use of a DASH is appropriate. You're going to want to also, though, document the rationale in the patient's medical record. The next question was, does stitches include major injury? The categorization of the level of injury for J1900 is based on the injury sustained by the patient, not necessarily the treatment for that injury. So major injuries include bone fractures, joint dislocations, closed head injuries with altered consciousness, and subdural hematoma. The next question was, where can I get a copy of the OASIS D guideline manual? I think you probably know the answer to this question now, but the draft version of the OASIS D guidance manual can be found in the download section on the Home Health Quality Reporting Program user manual webpage. The next question was, what would be an acceptable use of the DASH for J1900? Clinicians are expected to review the medical record and interview the patient and caregiver to obtain the information needed for accurate coding. The use of the DASH does have an impact on your reporting outcomes, so a DASH should only be used when no information is available. We had some questions about what to do with OASIS D being effective January 1, 2019, and what about active cases? The use of OASIS D is based on the MU90 date assessment completed. So if the answer to MU90 will be January 1, 2019 or later, you will use the OASIS D data set. If the answer to MU90 will be 12/31/2018 or earlier, then you're going to use the OASIS C2 data set. Another question about weighing patients. Can we use the patient scale for weights? Or does the agency need to provide the same for accuracy? And the response there is that weight should be measured in accordance with your agency policies and procedures. Now here's a question about falls. As a patient, you are training a caregiver, family member, or even a patient to catch themselves or stabilize the patient to intercept a fall. So why should that be counted as a fall? The answer is that the intercepted fall demonstrates risk, and this is consistent with how a fall is defined across all the PAC settings. Somebody wanted to ask, let's see. A question about, so a fall with therapy is not a fall because it is a risk of therapy. And clarify with, when you say therapist, are we talking about PTs or OTs or both? So CMS understands that challenging a patient's balance and training him or her to recover from a loss of balance is an intentional therapeutic intervention and does not consider anticipated losses of balance that occur during supervised therapeutic interventions as intercepted falls. And this would be true regardless of which of the agency's licensed staff are providing the intervention of intentionally challenging the patient's balance. Let's see. This is not intended to mean that every time a patient falls when working with a therapist, the fall would not be reported on J1800. The exception is intended to only apply to balance losses that occur as a direct result of the clinician shifting the patient's center of gravity for balance retraining, where a loss of balance is anticipated by the clinician.
Okay, so I'm going to go through a couple of questions. Will any of these measures be added to the value-based payment states? I'm not sure exactly what the person was asking here, but the response is, our mission today is to focus on the home health quality reporting requirements for value. So for questions for value-based payment, please go to hhvbpquestions@cms.hhs.gov. These will be posted later on, so you'll be able to get to that link. Another question is the OASIS item set finalized now, and is a copy being used on site in Baltimore? And CMS is still awaiting final approval with OMB, and we assure you that we are aware of the need for this document. They've been waiting for this, and they'll post it as soon as it's the final approval. So it has to go through a process at CMS. So then we had a bunch of questions that were very similar in nature, so I'll try to go through them. If a stage 3 pressure ulcer changed to stage 4, would it not be a stage 4 at the start of care and resumption of care? So let me just kind of step back a little bit. A lot of these questions are around that period of that initial assessment period of time, that 5 days, and they came all different flavors of that question. So the important thing to remember here is we're asking for the initial skin assessment to be locked in. So as soon as you do that initial skin assessment, even if something changes in your assessment period, for the initial skin assessment, although you might be able to change other items, for the skin assessment, you need to go with that initial skin assessment. And that aligns with all the other reporting requirements. So that's kind of the overarching answer. So if the initial skin assessment completed on admission to the home health service identifies a pressure ulcer, the stage of the pressure ulcer as identified on the initial skin assessment is what should be reported on the start of care OASIS. Any subsequent changes in the numerical staging would be reported on subsequent OASIS assessments. You would not change the initial skin assessment coding for the SOC or the ROC. And that goes for a variety of questions. This was asked that way. It was asked actually, let me go to the next question, and then we'll go through more of these. So a question asks, I rarely see physician documentation on pressure ulcers. Can we obtain nursing notes or wound flow sheets from the referral source and use that information? So the answer to that is a pressure ulcer / injury may be reported on the OASIS based on visualization of the wound, patient assessment and interview, review of relevant related historical documentations and clinical judgment, etiology. Although the assessing clinician can report the observed ulcer injury on the OASIS without a physician confirmation, collaboration with the physician is required in order to add the diagnosis and ICD-10 CM codes to the OASIS. Diagnosis items and the patient's plan of care, and to receive related orders and or provide physician-ordered care related to the pressure ulcer or injury. So hopefully that clarifies it. For the OASIS, you can go based off of the documentation and the assessment, and then you'll have to get physician documentation for the rest as far as for coding. If the ulcer is related to a device, nasocannula, ET tube, is on the skin from pressure or friction of the tube, is that considered a pressure ulcer? Sorry. Okay. So an example of pressure ulcer is so we basically talked about what is a pressure ulcer. So a pressure ulcer is localized injury to the skin or underlying tissue as a result of pressure. Pressure ulcers or injuries are defined as localized injuries to the skin and or the underlying tissue, usually over a bony prominence as a result of pressure or pressure in combination with shear and or friction. If pressure is not a primary cause of the lesion, do not report the wound as a pressure ulcer injury. And the mucosal injuries are not counted in the pressure ulcer coding based off of the education that we did today. Remember we talked about that the mucosal skin is different. Okay. Hopefully that answers that question for you. There was a question from, it says, on page 59 are the scenarios. I think it was scenario 2. The window allows 5 days for assessment, and then, so in the scenario, the initial skin assessment, could the answer be reflected as a stage 3? So let me just go through the scenario quickly, and I think this goes back to my initial answer that I gave. In the scenario, the initial skin assessment indicated the wound was covered with a non-removable dressing, and then on day 4, an order to remove the dressing was received, and the wound was staged as a stage 3. The initial skin assessment is the one that should be coded on the OASIS, so that would be unstageable due to a non-removable dressing. Even though in that 5-day period you're able to take, the dressing was removed. It's that initial skin assessment. Then we had another question that was basically the same, basically the exact same question, just worded a little differently. So again, it's that initial skin assessment. Here's another way of saying the same question. If you have 5 days to do the OASIS and you discover on day 4 that previously unstageable wound is now noted to be a stage 3, would that be considered on the start of care? Again, I know this is, people are struggling a little bit, but it is that initial skin assessment. So obviously this is an opportunity for us to go back, and this is probably a little different than your general practice, but the initial skin assessment, whatever that is, that's what's encoded on the OASIS. Let's see. Oops. Next question. Do we need a document verification of the unstageable site that was then staged with a physician? If so, what information is needed in that documentation? And how we're responding to that one is, the assessing clinician can report the observed ulcer or injury. I think this goes back to the one that I already answered. As far as the status item, without a physician confirmation or collaboration with the physician is required in order to add the diagnosis of ICD-10 CM codes, the OASIS. So again, based off in this situation, you would have had information with someone coming in with a wound underneath a, let's say, non-removable dressing or device, and you can encode that on the OASIS, and then if you want to add anything to if you want to add anything to the ICD-10 coding, you have to have physician recording that. Again, this last question goes to almost the same thing we've already talked about. Should you use the 5 days before coding an injury or ulcer? And so again, the initial skin assessment completed at admission to the home health service identifies the pressure ulcer. The stage of the pressure ulcer as identified on that initial skin assessment is what should be reported on the start of care OASIS. So hopefully that answers it. A lot of the same types of question, and it is all around that 5-day assessment period. So if you're in there on day 2, and you find something on day 4, it's whatever that initial skin assessment that you did on day 2. So that's it for questions so far.